Good evening. I would like to present a case. We'll discuss about it afterwards. The case is about a 44-year-old female that came admitted to the ER unconscious, driven by the EMT doctors where the transport where they started CPR. On her arrival to the ER, systole was seen, ALS was initiated, and she was intubated and started with amines. And during the CPR, the anamnesis was that she complained about chest pain, and the anamnesis was a little bit vague. Some said it was the day before, sometimes it started prior to her collapse, and she suddenly fell and then lost consciousness at the grocery store. The EMT found her in the coma scale 3, and they just took her and ran her to the hospital. The distance between the grocery store and to the hospital was quite short. The first ECG that they described was sinus bradycardia, with no other signs of the signs of STS changes. The major thing that was found in her physical examination was a JVD and a big abdominal mass, which was not turned there and was solid in texture. The initial lab was a pH of about 7, lactate elevated of 105, and you can see there was no electrical imbalance. Troponin was elevated of 0.144, LDH was 500, creatinine later became the white blood count, and the spontaneous INR of 1 to 27. It took about a half an hour from the initiation of the CPR. The patient was stabilized. She required high doses of norepinephrine and dopamine, and finally the ECG showed the sinus tachycardia without any signs of STT. Because of the the JVD, they have done a bedside echo, which showed a large RV with small left ventricle in size, and it was echokinetic. For that, they done an angio-CT, which revealed a massive bilateral PE. We continued and imaged her abdomen and head, which was the abdomen revealed a large abdomen mass of 12 to 15 or 17 centimeters, which was thought was a uterine myoma, and a head CT which shows no sign of bleeding. We asked for a surgical cardiothoracic consult, which decided that she is not a good candidate for thrombectomy, and we asked for clearance for the gynecological, surgical, and general surgery for the risk for her bleeding. And the reason for that was because she received the TPA, a bolus of 50 milligrams. After this bolus, she transferred to this cardiac intensive care unit. The total time from her arrival to the hospital till the arrival of the cardiac intensive care unit was about 4 hours. And the questions that we should ask for the crowd, which would use the TTM, is the pulmonary emboli is contraindication for hypothermia, and is the TPA is a contraindication for hypothermia.
I think one of the questions I gave in the answer to my presentation, that if you have a circulatory arrest, it is not a circulation. The brain does no difference, it's ischemic and protection. So the indication for TTM is there, even if it is from non-VF case. Now, what I would not know exactly is how TPA would work on this. Are you sure, by the way, that this is thrombotic clot? Or can it be other material than thrombus?
No, it was a thrombotic clot.
Okay. How do you know?
We done a CT, and then eventually it was thrombotic clot.
The only reason I'm asking, because I know at least one case very close to me in my family where a patient had surgery for a clear cell carcinoma of the kidney, and he had massive pulmonary embolism from the operation of that. So it's not necessarily always thrombus, but it is.
But the angio CT eventually showed that, and there was a consensus with the radiologist thrombosis. Yeah. About what?
Okay, but the answer on question 1 would be yes. On question 2, I would not know why it would be one indication, and about TPA, I'm not sure.
Because there is a high incidence of bleeding with hypothermia. So if you administer also a thrombolysis, maybe you get a high. So that's the reason that sharing some process.
Would you feel in therapeutic any patient was regardless of the issue?
I would say yes. If the patient is conscious and has fulfills criteria for therapeutic hypothermia, I would not care anymore about the cause of the background. Yes.
In the TPM study, they introduced hypothermia in non-BPDF patients only in those whom there was someone, a bystander, stopped showing the arrest. Not every assist. So if you see a patient collapsing and the first person is assisted immediately, that's not a question. But if you arrive to a patient who is assisted, that is not an indication for sure that he's dead. So that's okay.
Okay. Actually, when you're going over the evidence is quite vague. This is a good question. Nobody really answers it. Not in the guidelines, not in any good reviews and centers. I found only three report cases of similar events. One of them is in 2013. Actually, the article was in Serbian language, and unfortunately, I'm not a Serbian language don't speak language. And this they gave thrombolysis and did a TTM, and eventually there was no sign of bleeding. There are two more earlier reports, one in 2008 and 2007, which are similar events, in which there was no sign of bleeding, there was no sign of any other complications, and there eventually was well. But the problem is there's only 3 case reports in the literature. Actually, we did not use the TTM. We gave another 50 milligram bolus of TPA, and afterwards there was a good hemodynamic response. She was extubated about 2 days later, and after she woke up, we managed to find the amnesis, and she said it was a DVT 8 months ago, and she knows about the uterine myoma for more than a few years, and she refuses to operate on that, and there was no neurological signs. Yeah. Thank you.